Chapter 2: What you need to know to get started. The basics of cancer immunotherapy.
Cut, poison, and burn. Until recently, those have pretty much been the only choices cancer patients have had to treat their disease. They could cut out their tumors and often a few body parts, poison their bloodstreams with chemical cocktails, and burn their bodies with radiation, which itself can cause other cancers. But in the past few years, there has been a paradigm shift in cancer treatments, from medications that poison cancer to the new medicine that unlock the body's own ability to destroy cancer through the immune system. The concept of using the immune system to treat cancer is not new. In fact, it dates to the late 19th century when Dr. William Coley observed the patients who developed bacteria infections following cancer surgery sometimes fared better than non-infected patients, hypothesizing that the infected incisions caused the immune system to become active. Coley tried to explore this line of treatment by deliberately infecting patients with bacteria. Certainly, in the time before antibiotics, this created some problems, but it also resulted in some surprising successes as well. Unfortunately, his efforts were soon overshadowed by the development of radiation and chemotherapy. Sometimes the best does not always win out. Just recall the video format wars between VHS and Betamax. Betamax had superior picture and sound quality, but VHS won out and dominated the market until the rise of DVD. While Dr. Coley was initially optimistic about the potential for radiation to burn away tumors, the primitive state of X-ray technology led him to eventually determine it was ill-suited as an effective cancer treatment. While others disagreed and continued working in radiation treatment, Coley continued to study the effects of the immune system on cancer. In the meantime, chemotherapy became the mainstay of cancer therapy, despite its overall poor record of success. Even though Dr. Coley's work was for the most part ignored during his lifetime, today he is recognized as the father of immunotherapy for his contributions to this now burgeoning medical science. Following Dr. Coley's death in 1936, radiation, chemotherapy, and surgery remained the standard cancer treatment for the next half-century, and immunotherapy was relegated to the back burners of scientific research. By the 1980s, however, scientists began to reconsider the idea of using the immune response to treat cancer. Though the scientific understanding of the immune system was much better than it had been in Dr. Coley's day, the result of these early efforts were disappointing. It seemed that no matter what technique was used to stimulate the immune system to attack cancer, it was never enough to generate an effective immune response strong enough to eliminate the cancer. That is because cancer grows from the healthy cells in our body, so it can easily trick the immune system into thinking the cancer belongs there. Even more troubling, once it does so, it can turn the immune system against itself, causing immune cells to kill other immune cells that want to attack the cancer. This is the key concept to understand. The immune system has cells that are called regulatory cells, which are designed to protect you from autoimmunity, a condition caused by your immune system attacking yourself. But these regulatory cells can be hijacked by cancer and used as its personal bodyguards. When this happens, it is these regulatory cells that often are the most important barrier to an anti-cancer immune response. Blocking or destroying these regulatory immune cells is one of the key features to more successful immunotherapy drugs. In essence, as powerful as the immune system is, cancer has been even more intelligent. It is not just the fact that the immune system fails to recognize cancer that has made cancer so challenging to treat effectively, but also the fact that cancer is actively able to avoid the immune system. In simple terms, you can think of the immune system as having two main divisions: one designed to attack harmful foreign substances and the other to protect against an overzealous immune response, acting as defense against autoimmunity, the process of immune cells misperceiving cells in the body as foreign invaders and attacking them by mistake. I stress this again because it is important. The division designed to protect the body from a mistaken immune attack is known as the regulatory immune system. The regulatory immune system is obviously critical to reduce the risk of autoimmune diseases, which arise when the immune system thinks that the body's own cells are foreign ones and must be destroyed. The regulatory immune system helps prevent these mistaken attacks on the body's own cells. You can think of the protective regulatory side of the immune system as being the brakes, and the attacking side as being the gas pedal. No matter how much you push the gas, if the brakes are fully applied, you will go nowhere. Unfortunately, what that means when it comes to cancer is that the regulatory portion of the immune system prevents the rest of the immune system from attacking cancer cells because those cells are masquerading as normal, natural cells that belong there. Thus, failing to recognize the cancer cells for what they are, the regulatory immune system is an important protector of cancer. Despite these challenges, the concept of teaching the immune system to recognize cancer and destroy it has seemed like the best chance to create a cure in a high percentage of cancer patients. The immune system has its own intelligence and it has memory, both of which are crucial to seek out and kill cancer. A good immune response recognizes many targets on a cancer, so-called cancer antigens, making it harder for the cancer to hide. This is the weakness with some of one-dimensional treatments, which includes some vaccines and original versions of CAR-T, which generally targets one antigen. Later in this book, I will discuss in more detail how intratumoral immunotherapy, the injection of immunotherapy directly into a cancer, may be a good solution to this problem. Given this complexity of the immune response, indiscriminately enhancing the immune system is an effort to treat cancer may not always be a good idea because doing so could strengthen the regulatory system's protections against autoimmunity and thus protect the cancer cells. On the other hand, it is well known that chemotherapy weakens the immune system, which is often considered a bad side effect. But certain chemotherapy drugs may also weaken the regulatory immune system, which may in turn enhance the anti-cancer response of the immune system. For this reason, medications are often used to reduce the regulatory cells of the immune system, which seem more susceptible to certain chemotherapy agents. Low-dose cyclophosphamide is one of these. However, it is important to point out that it is low dose and usually does not have the typical side effects as when used as a high-dose chemotherapy agent. Most patients should not have any of the side effects that they would experience with standard chemotherapy-type doses. Are you sufficiently confused? You should be. Cancer and cancer treatment is confusing, given the complexity of the immune system. But what all this means in a nutshell is that the immune system attacks foreign bodies. We call this the effector response, while the regulatory portion of the immune system prevents it from attacking itself. Because cancer disguises itself as a natural part of the body, the regulatory system gets fooled and protects the cancer. It lets cancer cells grow, thinking they belong there. Compounding this problem, these regulatory cells may often produce substances to assist the cancer in growing and suppressing the effector, anti-cancer immune attack. Typically, cancer could not survive, or at least thrive, without the help of the regulatory immune cells. These regulatory immune cells become accomplices to the cancer. As they say, with friends like that, who needs enemies? The challenge to successful immunotherapy has been to overwrite the regulatory system, while at the same time strengthening the rest of the immune system, and the challenge has been nearly insurmountable until recently. In the mid-1990s, Dr. James Allison, chairman of immunology at the University of Texas, MD Anderson Cancer Center, discovered some of the key mechanisms that result in putting on the brakes of the immune system. Dr. Allison had long been a pioneer in the study of T cells, cells that are fundamental to the immune response. Think of T cells as the immune system soldiers, the killer T cells which attack foreign invaders. There is another type of T cell called a helper T cell, which organizes and helps other cells do their job in the immune system. These T cells, along with other immune cells, contain receptors that can activate regulatory T cells, called TREGs, which determine if something is friend or foe. If these regulatory T cells determine something is foreign and dangerous, signals are released to stimulate an attacking immune response. If, on the other hand, they identify as a friend, the regulatory T cells tell the immune system to back off. But, as I've said, cancer cells have corresponding receptors which send deceptive signals to the regulatory T cells to trick them into thinking they are friends, and a natural part of the body not to be attacked. Dr. Allison's understanding of this process led to the development of a series of drugs known as immune checkpoint inhibitors. Essentially, these drugs inhibit the immune checkpoint response by removing cancer's disguise. By blocking the signal, the immune system can potentially see the cancer for what it really is, something dangerous and that needs to be destroyed because it doesn't belong in your body. Based on Dr. Allison's research, in March 2011, the FDA approved a drug called ipilimumab, more commonly known by its brand name Yervoy, for the treatment of melanoma. The approval of this exciting new drug, which helps remove the brakes of the regulatory immune system, unleashing the attacking side to go after the cancer, heralded a change in thinking that began a revolution in cancer treatment. A key weakness had been discovered, and even though the initial immune checkpoint inhibitors may not be the ultimate cure in their own right, they have certainly lit the way. More significantly, after the development of this first immune checkpoint inhibitor drug, researchers realized that removing the brakes of the immune system was a key step in coaxing the immune system to unleash the body's own defense system against the cancer. This has led to a new understanding in cancer treatment and many future drug therapies. The potential for immunotherapy to become a leading treatment for a variety of cancers is now within our sights, and for many patients have already proven life-saving. I would be remiss if I didn't also mention Tezuka Honjo, MD, PhD, and his work researching a protein known as a programmed cell death protein 1, PD-1. PD-1 is found on the surface of cells. Like regulatory T cells, its function is to regulate the immune system's response to other human cells, thus also preventing autoimmunity by minimizing T cells' inflammatory activity. However, also like regulatory T cells, PD-1 can prevent the immune system from recognizing and killing cancer cells. Dr. Honjo's study of PD-1 led to the development of a new class of drugs called PD-1 inhibitors. At present, they are the most widely used immunotherapy drugs. Both doctors Allison and Honjo were awarded the 2018 Nobel Prize in Physiology or Medicine for their work that led the development of immune checkpoint inhibitors. Since approval of Yervoy, several other important new drugs have been approved by the FDA. The current, most popular immune checkpoint inhibitors in clinical use are ipilimumab, trade name Yervoy, nivolumab, and pembrolizumab, under the trade name Opdivo and Keytruda, respectively. On May 18, 2016, the FDA approved atezolizumab, under the brand name Tecentriq, for treatment of bladder cancer. Since then, Other PD-1, PD-L1 drugs have been approved as well. There are many other drugs that are in development and will probably soon gain approval. But for now, these drugs are our primary medication used in immunotherapy and will be an important focus of this book. Before going any further, there are a few key concepts that you need to understand if you or someone you love is considering immunotherapy. Number 1, it does not always matter what type of cancer you have. There can be a potential for immunotherapy to work. Early efforts to treat cancer had assumed that cancer was cancer. But we now know that there are over 200 different types of cancer. That means what works for one form of cancer may not work for others. But don't let that fact discourage you. One of the most exciting features of immunotherapy is that because it works in conjunction with the body's natural immune system, it has the potential to treat many types of cancer, and hopefully, as new drugs are developed, maybe all cancers. Different cancers may have the specific immune weaknesses, and those are being rapidly sorted out with current immunotherapy research. Unfortunately, I often hear from patients who have been told by their doctors that immunotherapy does not work for their cancer type. I think if you look at the research, however, and the swift pace at which immunotherapy is gaining approval, you will agree that it is probably not true. I do admit that current CTLA4, PD-1, PD-L1 drugs may still be lacking. While it is true that some cancers are more immunogenic and respond better than others to immunotherapy, there is the potential for all cancers to respond to immunotherapy, particularly when used in combinations, directly injected into the tumor or together with ablation procedures in a specific manner. I have many patients with lung cancer, bladder cancer, and kidney cancer who were told that immunotherapy drugs would not work for their cancer. But now these same drugs have been approved for those cancer types. Because it takes years of research before the FDA will approve a specific drug for a specific form of cancer. The FDA approval process is a slow one. While drugs cannot be prescribed in the US without having been approved by the FDA, once approved for use for one condition, FDA approval is not necessary for a physician to prescribe that drug for a condition for which it has not been approved. This is known as off-label use and is quite common. That means that while Yervoy was first approved for the treatment of melanoma, physicians can still prescribe it to treat other cancers. Number 2. Typically, your health insurance will not cover the costs of drugs without FDA approval for your specific form of cancer. But combining immunotherapy with cryoablation or directly injecting the drugs into the tumor can drastically reduce the costs of medications. Unfortunately, insurance carriers will almost never provide coverage for a drug used to treat a condition that the FDA hasn't approved it to treat. That means that if the drug your physician prescribes has not been approved by the FDA to treat the specific form of cancer you have, it may be almost impossible for him or her to offer you a standard immunotherapy treatment that is not directly covered by your insurance, even if it may work. Yervoy, for example, may be covered by your insurance carrier for treating certain cases of melanoma, but not for treating other cancers. With a price tag at over $30,000 per infusion and a course of treatment requiring a minimum of 4 infusions, it remains a treatment that many patients cannot afford. Bristol Myers Squibb, the makers of Yervoy, does offer a patient assistance program that may reduce costs, but it may still be such a steep price beyond the reach of many. There is also the difficulty of finding doctors who may be willing to offer these medications off-label. Also keep in mind that we are mainly discussing advanced stage 4 patients, for which standard therapies may have failed or been of limited success. Even though the drugs are available outside the United States, where in most cases they would be much less expensive than they are in the US, immunotherapy pricing remains fairly steep throughout the world. But don't let the price of these drugs discourage you. The key aspect to injecting the drugs directly into the tumor, rather than into the bloodstream, means that even without ablation, it may be possible to achieve the same or better results with a fraction of the dose, and at a fraction of the costs. In other words, whereas standard immunotherapy treatment involves infusing the drugs into the bloodstream, by combining immunotherapy with cryoablation or directly injecting these medications into the tumor, the effectiveness of the treatment may be enhanced while the price of the treatment is dramatically reduced. Number 3. Combination immunotherapy is generally more effective than any single agent. The anti-cancer immune response is as complex as is cancer itself. It is highly unlikely that one agent alone is sufficient to generate an effective anti-cancer immune response. Not only does CTLA-4 help tumors to suppress the immune response against them, PD-1 also plays an important role. It has already been shown in clinical trials that the combination of anti-CTLA-4 and anti-PD-1 inhibitors is significantly more effective than either one alone. Just recently, the FDA has added approvals of this combination for certain melanoma, kidney, and colon cancers. Unfortunately, just as success increases, so does the cost and side effects of the two drugs just as significantly. This is one reason that we inject the medications into the tumor microenvironment where they need to be. You want the immune response to be directed against the tumor, and where that is more likely to occur is at the tumor site. Once the immune system learns how to respond in one location, it is better able to attack cancer elsewhere in the body. In addition, a treatment such as cryoablation, which is the direct freezing of the tumor, has its own immune-stimulating properties. It can be considered an additional form of immunotherapy to be used with immune checkpoint inhibitors. And because ablation is minimally invasive and tumors are treated with a needle under image guidance, it is the perfect opportunity to administer other immune agents, such as the checkpoint inhibitor drugs, directly into the tumor at the same time in one procedure. Throughout the history of modern medicine, we have found many remarkable powerhouse treatment combinations. A great example is the treatment of HIV/AIDS. Just a few decades ago, an HIV diagnosis was a terminal one. But the current medications used today in combinations have had great success and patients can live long, relatively normal lives with their disease. But when these same drugs are used alone, there is only a modest survival increase. Hence, the lessons we have learned in treating HIV patients supports the importance of combination therapy in treating disease, and cancer is no different. Immune checkpoint inhibitors not only help unlock a natural immune response, they can be essential for helping other immune therapies turn from bust to boom. It's that synergistic immune response that enables cancer treatments to become far more effective than ever before. While our knowledge of immunotherapy is still developing, we have finally reached a point where cancer patients, like former President Jimmy Carter, can recover from malignant and fast-growing tumors previously thought hopeless. And when I talk about hope, I'm not talking about just passively sitting back and hoping for a cure. I'm talking about taking charge of the recovery process by doing everything possible to give the immune system a fighting chance against cancer.